So my background, I'm board certified in psychiatry and addiction medicine. I'm based out of Chicago, Illinois, in the United States, and operating right now currently three clinics that offer ketamine services in downtown Chicago, and then a couple outside in the suburbs. Just kind of getting into my perspective here, you've already heard a lot about the efficacy and the data. Basically, what we're seeing here is a paradigm shift in psychiatry. And, many years of practicing with limited tools. I was growing quite frustrated that I was hoping to have, more robust effects, responses, quicker responses. I wanted more tools to keep somebody out of an inpatient, setting if I could, and treat them outpatient, especially when they're in crisis and experiencing suicidal ideations. And really, the paradigm shift that we're seeing is that, we're looking at novel mechanisms of actions that we're just kind of covered right now, looking at the NMDA receptor, looking at the concept of neuroplasticity, looking at altered states of consciousness. Things are changing in the field. And I think what's really helping drive this paradigm shift is that one is the efficacy and response rates are much better. The effects are quicker, but there's also the concept of, there's a psychoanalytic approach to our field. There's a biological approach of the last few decades, then psychoanalytic approach for decades before that. But finally, I think ketamine really helps bring it right to the intersection between the biology and the psychology, and really trying to get to the root cause of what is kind of causing the depression in the first place. I mean, we know that the future is looking good, where all novel drug development is heading in towards now this new mechanism of action, looking at glutamate modulation, looking at psychedelic medicines, and really the negatives of the current treatment options, we're trying to avoid those. I mean, we know the STAR-D trial, we know about the high dropout rates from traditional SSRIs and SNRIs. So I opened the first practice up. The first practice to offer ketamine, a psychiatric-based ketamine practice in the Midwest. It was the second overall. It was something that when I took that risk, I obviously was feeling quite anxious about it since there were none. And that at that time, what really got me, I guess, to that point of wanting to do it was actually the study was what Dr. Seidman had brought up about Dr. Zarada's breakthrough study. And because that gave actually some framework of how to actually do it in an outpatient setting. We think, especially in psychiatry, we're not always comfortable with an IV setup in our outpatient clinics, or a med that we know can cause altered states of consciousness in an outpatient setting. So there's a lot of nerves going in. I mean, my very first patient is when I knew I made the right choice to bring this treatment. I mean, somebody who had suicidal thoughts off and on for years, had tried ECT, tried TMS, tried pharmacogenetic testing, pretty much every class of medication, at least 10 hospitalizations. And after one infusion, suicidal thoughts had resolved. And by the fourth infusion, the mother was crying, I have my daughter back. That kind of an impact. I'm like, I understood that we're early at this and there's more safety data needed. There's more, yes. But at that point, my mind shifted that it's a real travesty to not be able to offer something like this that can work this well for patients especially that are in dire need and have tried so many other treatments. When we look at risk benefit analysis compared to what's existing, as the years have gone by, I think my perception's changing, where I really feel such a higher level of confidence when it comes to the safety of ketamine now. We are now 50 clinics just in Chicago. After we opened our doors, they've continued to open. Our clinic offers Spravato as well and deep TMS. I know an Israeli-based company, Brainsway, and we also have intramuscular and oral ketamine-assisted psychotherapy. But our mainstay is IV ketamine in our practice. We offer psychiatry psychotherapy services for patients who don't have care providers. However, collaboration with referring providers is a huge part of what we do. And really that goes to, what do you do with medications in the context of ketamine now that somebody's improving? When do you start changing meds? We really collaborate with the treating physician to help guide them and really make it a team effort. Right now in ketamine, when we just say it's not covered by insurances in the United States, it's considered experimental and investigational. There is lack of FDA approval. But that's changing. One is, we already know that Spravato in the family of ketamine is an isomer. S-ketamine's got FDA approval. The data is more robust than IV ketamine. It goes back longer period of time. And insurance companies are, even though it is not yet FDA approved, and that's because it's generic, it hasn't been presented to the FDA. Officially, it takes obviously, time and money to get a drug passed through an FDA. And being generic, it hasn't had that advantage, but the data goes back, and now there are commercial plans starting to cover it in some states like Blue Cross Blue Shield, Massachusetts, or Vermont. There's some plans in Utah, and we're working with our plan in Illinois to start getting insurance coverage. And what that means is there's a domino effect about to happen, where eventually patients would be able to, who can't afford it, might be able to get access to care by just using their insurance card for this treatment, integrated into the medical model, not standing as just a unique on the side kind of service line clinic. I think the future trend will be in the United States, where you'll find it at most healthcare systems and covered by insurance payers. Ketamine works amazingly well, but there's an infusion series of 6 treatments that we've discussed already. But one thing to point out on it is because of the duration of benefit not lasting, there is an optimization phase where patients come in whenever the benefit's wearing off, and then they extend that interval between treatments further and further until they kind of plateau at a maintenance interval. And some patients may need treatment every 2 weeks. At worst case scenario, I've seen 1-2 weeks, and the best case scenario, I've seen every 8 months. I think in our practice, our average interval is every 7 weeks, which is longer than what the data shows that the benefit of ketamine is. And what that really speaks to is the concept of neuroplasticity. And the more a patient makes utilization and benefit from a neuroplastic state, more psychotherapy, more behavioral changes, optimize their medications, do everything else outside of ketamine, because our goal actually is to keep patients maintaining at the least frequent possible interval. And if they're coming in more frequently, we're increasing intervention. We really stress that you need to do more outside of it. And a neuroplastic state allows them to make that change and stick with it. And that helps you need less frequent intervals, is what I've seen anecdotally in our clinics. But there is a maintenance element to ketamine. If somebody has not tried a lot of treatments, but has acuity, suicidality is severe, the language is different and our treatment plan is different. We want to use ketamine to get them out of their acute crisis episode. But if then, as they're maintaining, we're going to want to work in all the traditional treatments, which can help space out the need for ketamine and eventually graduate off of it is our goal. Versus if somebody's tried everything already, they're very treatment refractory, there's probably going to be an ongoing maintenance to it. We've done 5,000 infusions since we've opened our doors. We've treated between 11 years old and 89 years old of age group. The 11-year-old was probably one of the youngest in the country to be treated. It took me 2 years before I agreed to treat that patient. And the parents had tried every possible treatment, and it was suicidality, self-injury, and ketamine, that person's maintaining every 4 months with one treatment. It pretty much put that child in remission. And I've seen over the years that there are studies now underway for adolescents. I'm seeing that the younger age groups, like that was pointed out by Dr. Seidman, and when we're looking at the ECT studies, I find that younger patients tend to actually do better as well, anecdotally, versus maybe somebody who has more of a rigidity in their cognitive framework. We are treating MDD, treatment-resistant depression, which when I started used to be defined a little bit more in a strict manner because it was such a new treatment. But over the years, and now there's such a high level of data out there, and especially when the FDA approved Spravato and defined treatment resistance as 2 failed antidepressant med trials, that I'm keeping IV ketamine in line with that in my practice, where if you failed 2 failed med trials, which honestly in a treatment refractory clinic is a lot of patients, we're we're okay with doing ketamine. PTSDs are second most common, which I know is probably rampant in Israel, and just considering the climate there and the history there, we find amazing results, for PTSD. Bipolar depression, we just watch out for triggering mania, but it works very well for that too. We do it for acute suicidality. We do it for alcohol use disorder in our practice, generalized anxiety disorder. We even do it for OCD. Mixed results there, to be honest. I'm not totally sold on that indication. I've done it for chronic traumatic encephalopathy, CTE. Benzodiazepine and opioid withdrawal, it can really help modulate glutamate and GABA, and that homeostasis, which really can help in a slow detox off of buprenorphine or heroin or methadone, or it could help if somebody's trying to get off alprazolam or a benzodiazepine. So we actually looking at our outcome data, we analyzed 3,500 treatments in our clinic. I have a lot of secondary endpoints. I have a lot more data behind it. I just wanted to give the high level of what was our main response and efficacy. For PHQ-9, it was defined as either full response, more than 50% improvement on the PHQ-9, or getting a score below 5 to achieve remission. Our efficacy was 70% at our practice. We saw PTSD with very similar results, maybe slightly better, but similar. We saw generalized anxiety disorder, slightly less than that, but similar. So, and we have, we're now analyzing our second tranche of data and mining it, and hopefully we'll have a lot more insights on dosing and intervals and all of that. We do start at 0.5 milligram per kilogram, but we do go up on the dose through the course. We do find that dissociative experiences, mystical experiences, I didn't believe it at first. I'm a very hard evidence-based medicine approach. The data, I saw that study, and when it came out, it said it didn't really link it. And there are so many patients who were improving without a dissociative experience with the IV form. And we sometimes, because it triggers such anxiety, will tailor the infusion to be less dissociative, stretch the time of the infusion to bring the Cmax down a bit, change the curve on it to make it basically a less intense experience, pre-medicate if we really need to with the like maybe midazolam, small dose, these kind of, and maybe lower the dose, all of these to get somebody to have less dissociation, and they still can improve. But with time, I've noticed that people that are really getting a psychological breakthrough, reframing of an intense trauma during the infusion with a new vantage point, new perspective and clarity, but without all the associated negative emotions like anxiety, fear, anger, is rapid trauma therapy in those sessions can occur. When those are happening, we do definitely find that higher doses give a better durability of effect, as there's a higher chance of a psychological breakthrough, an ego death, viewing yourself from a new angle and kind of having a rebirth of your ego. When those kind of experiences happen from ketamine, we'll chase it a little bit during treatments for some patients, and some patients will design the treatment to not be that intense or dissociative. So it really varies person to person. Safety, and I know that's a big part of and big worry about a lot. And we've in a little under 5,000 treatments. Only one treatment was there ever a call to the emergency room or the EMS to take somebody for an ER evaluation. It was a pseudo seizure, ended up being conversion reaction from a traumatic replay during like an intrusive memory during the infusion. Probably didn't need the ER call, but I, just to be on the safe side. Never have to stop. Only one time did we stop an infusion for blood pressure. We have continuous monitoring, of all the important parameters. Our nurses are ACLS, Advanced Cardiopulmonary Life Support certified. Medical providers are always on site, and there it is a very well tolerated infusion. It just it takes time to, I think, for people the first couple infusions to get past the experience of it, and then it turns in a lot more into a routine, and it can really be a very straightforward kind of process. We have PRN medications we use for blood pressure, anxiety, nausea. They work great when we need them. We don't need them that often. Patients, from a logistics standpoint, outpatient psychiatry like practice or outpatient clinic practice, and you're trying to do ketamine, it's not an anesthetic dose. People aren't falling asleep. We have a crash cart here, sure, but have never needed to use it. Knock on wood. But we don't let them drive out of the facility. They need a good night's sleep before they can drive. We don't use alcohol and drugs. We screen them well. We do toxicology testing, substance abuse assessments, and we tell them don't make big decisions that day. We make sure their setting is good. You don't just give ketamine and with a lot of stimuli, with fluorescent lights, multiple patients in a room, and in a very hospital type feel. All that stimuli will cause the setting to be bad. We make sure we prep them for their mindset to go in as well and utilize the neuroplasticity and have an optimistic approach, which ketamine will actually help enhance that. So paying attention to those things, which Dr. Seidman and Dr. Drescher know very well with ketamine, and how to provide it in Israel in a setting that makes you have the best outcomes. And really, it's a tragedy at this point for anybody. When I hear of a suicide, like Dr. Seidman was saying, it really, it hurts because this treatment does work really well for that. Not for everybody, but when you look at the response and efficacy rates, way more often than not, we're looking at that 70 to 80% range of efficacy and a pretty rapid response in dropping suicidality. So it's something that I feel should be offered across the globe to people that are experiencing suicidal thinking. But I appreciate it. I'll stop now. I know we're a little over time and want to answer your questions.
Dr. Nazeer, thank you very much. Once again, we're going to put up a quick poll question. And this is regarding what disorders you think you would be most likely to refer for ketamine therapy. I'd ask Yasmin to bring all of the panelists on screen now. We received a myriad of questions. I was very pleased to see a myriad of questions that range from the scientific to the clinical protocol of use, and then some questions about Israel, the Israeli context specifically. So in no particular, actually, I was about to say no particular order, but in one particular order, I'd like to ask Professor Drescher to answer and translate, answer in both Hebrew and translate into English the two questions we have in Hebrew. Do you have those on screen? You're on mute.
Okay, sorry about that.
Excellent.
Yes, the first question is, באילו מינונים קצב היית אומר שמתאים להשתמש בקטמין לטיפול בכאב נוירופתי? Which is in English, what dosage and rate of infusion would you use for ketamine in the case of neuropathic pain, presumably chronic neuropathic pain? There are protocols. I don't want to give the dose right now off the top of my head because I don't know it. But there are protocols for chronic pain in general. Generally, I can say that they're sub dissociative doses and rates. And more than that, there are protocols that exist for various kinds of pain. There was one other one that I think I answered, which was in Hebrew. How long does it take to typically get a response from treatment? My understanding being a person comes for their first treatment. How long does it take them to feel better? In my limited experience, it is within a day. But I certainly let my colleagues with more experience in using ketamine, Dr. Nazeer, Dr. Seidman, do you agree with that?
For how fast a patient would start responding?
Yes.
Yeah, I know statistically it's actually between infusion 3 and 4. However, to be honest, I think suicidality responds quicker from what I've seen. Then I've seen the full noticeable response. Usually it could be anywhere in the 6 treatments. We used to only do 2, and if you didn't respond, we're like, it might not work. That was in the very beginning. That's changed now because there are late responders. If you're on like a high dose, if you're on a lot of benzodiazepine, you might have a delayed response as it can blunt some of the dissociative effects. So I usually tell people that it could be anywhere in, but majority of responders will respond somewhere in the first 4 treatments. And suicidality, I feel, responds quicker.
Okay, so let me ask another interesting question. Is the experience of ketamine characterized by the mystical experiences that are described in the use of other psychedelic-assisted therapy? Or, I think I'll stop the question there. Is the experience of ketamine characterized by the mystical experiences of other psychedelic-assisted therapies? Dr. Seidman?
The short answer is yes. It's somewhat variable, and there are 2 or 3 new ketamine-like compounds being developed that minimize the dissociation. The huge open question is, to what extent does the experience have any relationship to the outcome, the antidepressant outcome? And one would think you could study it by making people unconscious, putting them out and giving them ketamine versus having them have the experience. But anyway, it's not really known. Certainly some people, one of the most interesting things, again, I mostly prescribe intranasal ketamine in New York City. One of the more interesting responses is people who don't have a very good experience. They don't enjoy the dissociation, it feels strange. Again, it only lasts 30 minutes or so. It's not a big deal. We almost call it a side effect. And yet they call the next day and say the depression lifted. So it's not clear the relationship of that experience, that dissociation, to the ultimate outcome, which is the antidepressant effect. But as an aside, it's quite a phenomenal experience. Almost everyone who goes through it says that they've never experienced anything like it. One's consciousness goes to places that it has never been before. I mean, these are people who are psychedelic naive. They go places.
Psychedelic, yet it does have some of those similar effects.
Right. Anyone who takes a psychedelic steps back and says, wow, I did not know my consciousness could go there. Again, there are no words for it, really. That's one of the ways it's described, that people can't even find words for what's happening in their consciousness.
It's a fascinating research subject if the mystical experience is integral to the therapeutic effect. Along the lines of therapeutic effect, another question we had is, and this particularly for Dr. Seidman and Dr. Nazeer, what is the success rate of IV ketamine compared to intramuscular ketamine? And I guess I would ask further to that, in what circumstances would you find one delivery preferable over another?
I think Dr. Nazeer has enormous experience with this, and I would add to the question, include Spravato in your answer. What's your sense?
So I only utilize Spravato for intranasal in my practice. So that's kind of the marker I have. And in general, it has less efficacy when you look at the data. However, that's like probably not a really good way to frame it, because like some of it depends on study design. Like Spravato's efficacy, I think somewhere around 55%. They allowed up to 6 milligrams of benzodiazepine equivalent into the study. They had a very high benchmark the way they designed the study. It made it hard to show the right efficacy rate, but they still achieved it. And many of my IV patients will switch over from an IV onto Spravato, especially when their maintenance interval is not long enough and it's cost prohibitive, and they'll make a transition on the Spravato and it goes pretty smoothly, especially when you want to just take over and let Spravato do the maintenance and you can't continue on with the IV infusions for whatever reason. So we don't use as often, but I'm going to say, and there's not nearly as much data on IM. I mean, it's a lot less compared to IV. IM just in general it's more intense, and it's a different way of giving it. We'll sometimes swap out the IV for an IM because somebody's a very difficult IV line to get. But in general, we tend to do IM more with very much linked with psychotherapy facilitation, and then a longer psychotherapy session after. It can be a lot more dissociative. Whenever you just administer ketamine, and 90 to 96% bioavailability on IM, you get a lot of it in your system, but the curve is different. The spike is higher, Tmax is higher, the Cmax is higher, Tmax is shorter, and then it kind of drops down. So it's a little more of a rocket ship elevator type feeling, whereas IV gives a lot more of a smoother curve and experience, and you have a lot more control over it too, how fast you give it, 100% bioavailable. So I'm definitely preferential to compare the other two treatments, but intranasal, it allows for access to care and makes it affordable for patients. And like I said, I've had great success rates in people. So I always find IV to be, and from a statistical standpoint and what's out there, it has the best data, but there's a role of each formulation of ketamine and a benefit to each one and a disadvantage to each one.
Yeah. The way to study it is to have the group of patients randomized to the different treatments, but even that's not good because there's such inter-individual variability. And so the anecdote from clinics like yours is really to have patients try the different modalities and let them tell you what seemed to be best. Just like we do with Prozac, Zoloft, Paxil, Lexapro, and Celexa, real depressives eventually try all of them and say, yeah, this is the one that's right for me. I suspect that's the direction this will head. Ketamine will be widely available ultimately, and people will eventually have their preferred way of use. Professor Drescher likes us to use the IV because we have great medical control with the IV. We've had a couple of patients who had a little nausea or whatever, just turn it down and everything's gone. Whereas if you'd given that patient an IM, you're kind of stuck with whatever they're experiencing.
Thank you very much, Drs. Nazeer and Seidman. And Dr. Seidman, you provided an excellent pivot to the next couple of questions as you referenced the expansion of availability of ketamine for mental health. Obviously, the United States is considerably further ahead than Israel is, though Israel is being a much smaller country and respecting evidence-based medicine is quickly moving in this direction. Obviously,
not so quickly. Not
as quick as we'd like to see, but it is changing, and we've seen changes in the last several months. There's a couple of questions about Israel specifically. The first one is about the cost of ketamine therapy in Israel.
Well, maybe I'll take that one. Spravato, S-ketamine intranasally is recognized as is in the basket of treatments that the health maintenance organizations are required to give, and so it's essentially free. People get it. All they need to do is get a place, which we hear often is difficult. And there's the other disadvantages to whatever to Spravato and advantages, but it's free. IV ketamine is not subsidized by the HMOs, since it does not did not get the official, for all the same reasons we've been discussing, did not get official FDA or subsequent Israeli approval, and so it's not officially in the basket of funded treatments, and so it needs to be paid for privately.
And the price comparison is about half that of the average price in the United States right now, and that's what KetaMind is able to offer. Because it's not in that basket, we go through the 29 Gimel process for all patients.
That's a separate issue, though. We have to go through 29 Gimel because it's off-label.
Right.
In the basket has to do with being covered by insurance.
But it's all. It's not. Yeah. It's all. I mean, the connection is that it's not covered also because it's not recognized by the government. That's so that we need to get so both the coverage and the ability to use it both kind of come down to it's not being in the basket of approved treatments.
And the 29 Gimel process, there was a question about that. Does the health ministry grant 29 Gimels reliably? And I believe in our experience, the answer is yes, because of the process for patient screening and patient acceptance for ketamine treatment at KetaMind. And we've actually seen the turnaround time on getting 29 Gimels granted come down to frequently within the same day.
Yeah.
Let me ask one.
I'd like to say that's Professor Drescher's doing. He spent a lot of time and energy finding the people and defending this treatment in the way it needed to be defended in Hebrew.
Indeed. I just because we're at time, perhaps I'll just ask one more technical question that came through, and I'd like to invite all of the attendees to reach out to us with, or any of the panelists you wish. We'll make sure that your questions or requests for contact get to them. I'd like to put our contact information on screen while I ask the last question. Would the 0.5 kg dosage be a good starting dose for treating a case of neuropathic pain combined with depression? Very specific technical question.
Well, in my opinion, the answer would be yes. I would like to. I don't want to speak off the top of my head regarding pain protocols, but certainly it's a good starting dose for treatment-resistant depression. And in fact, in our anecdotal experience, some of our patients do have pain, and there does seem to be an improvement. Of course, that's not surprising. Depression and pain being kind of synergistic. But I would say that without making that as an official recommendation, it sounds like a reasonable dose to start.
I think there's a oh, sorry, go ahead, Dr.
Well, I could add, and I actually would like you to answer, Dr. Nazeer. I can add, what's not talked about a lot is how terrific it is for anxiety. It really is quite amazing sometimes for anxiety, in my experience. But I wonder about yours, Dr. Nazeer.
Yeah, well, I mean, that's kind of the beauty of this novel approach because of the pharmacology of it. and how we're affecting neuroplasticity and modulating at the glutamate level, it's a broader, there's broader use case scenarios. And the majority of patients do have a dual diagnosis of an affective component like depression with some sort of anxiety disorder. And when we have our outcome data for generalized anxiety and for panic, PTSD, they're all very similar to the depression outcome data we have. So meaning roughly in that 70% efficacy range, maybe a little higher, maybe a little lower, but that is still much better than, looking at traditional pharmacology. So you're actually getting I guess you're getting just a wider kind of a benefit than and compared to older approaches. I will say on the pain part, we in my practice, we don't do it for pain just because, I'm not comfortable. I'm a psychiatrist. I think the anesthesiologists, ER docs will be more comfortable for those protocols. They're usually higher doses to some degree overall, and then longer infusions. When you look at CRPS or RSD, reflex sympathetic dystrophy, complex regional pain syndrome, phantom limb pain, severe pain syndromes like that, they're usually higher dosing, 3-4 hour infusions sometimes, different price points, different everything. But patients that are coming in that are depressed, yet they have a neuropathic pain, fibromyalgia, some other, a more of a minor pain syndrome, not one of those real major ones. We do it as if we're treating depression, which is, again, starting at 0.5 milligram per kilogram. And then we see a secondary benefit under neuropathic pain. Sometimes it's not long-lived, it's a short-lived benefit, kind of wears off, but it does provide them, especially through that 2 weeks, some relief. And that's just a secondary benefit, even though that's not what we're targeting. And our protocol is coming at it as if we're treating depression, which is the primary diagnosis that they're at our clinic for.
Thank you. Thank you very much. I want to express appreciation on behalf of myself and my colleagues at KetaMind for everybody who's attended this evening. I'm very happy to say it's been very well attended, not just in the people who joined us, but the kindness for bearing with this webinar going longer than intended. But the presentations were excellent. The questions were great. Again, thank you to all the attendees, and a thank you to all the panelists, particularly Dr. Nazeer joining us from the United States. Please, you'll be able to revisit this or forward this by looking at KetaMind Clinic's website. We also have a YouTube channel in which each of the individual presentations will be posted. And as I said earlier, please don't hesitate to reach out and contact us for any reason. Thank you very much, everybody. Have a good evening. Have a good day.
Thank you, Chaim.
Thank you.
Thank you. Thank you, Chaim. Thank you, Yasmin.